Folks, welcome back to the next episode of the Dental Implant Podcast. And I am very, very excited to have Dr. Abdelsalam Elaskary with me today. And Dr. Elaskary is the founder of the Vestibular Socket Therapy Treatment Protocol. And I'll explain why this is so exciting for me in just one moment. He's the owner of Elaskary and Associates Clinic and the educational institute located in Alexandria in Egypt. He is currently a visiting lecturer at the University of New York and president of the Arab Society of Oral Implantology in Cairo. He's authored 3 fantastic textbooks in the field of dental implantology: Reconstructive Aesthetic Implant Surgery, Fundamentals of Aesthetic Implant Dentistry, and Advances in Aesthetic Implant Dentistry. And all 3 are published by Wiley Publications, and they've been translated into several languages. He's also authored numerous articles in the field of implant dentistry. So, Dr. Elaskary, if I've missed anything, please do feel free to expand on that. So one of the reasons why I've asked you to join us today is the VST technique. So I hear it a lot, and I think it's taught a lot as well. And from a very basic level, that if you don't have buccal bone, or if the buccal bone's very thin, you have to go for a delayed protocol. And there are a number of institutions where they say this, and there is some evidence to suggest that if the buccal plate's very thin and you immediate place, that is going to disappear. Now, whilst that's true, there are techniques that we can use based to bypass this. And your techniques is one of the ones that I want to discuss today, the VST technique. So what I'd like for you to do is as well as telling us a little bit more about yourself, tell us how you came across the idea, what the technique is, and it's something that I use already, and it's absolutely fantastic. So even if you don't have any bone, or the buccal bone's very thin, or you've got periapical lesions around this, you can immediate graft very predictably. And the results that you're getting are absolutely stunning. So I'm going to pass over to you now, if you wouldn't mind telling us a little bit more about yourself.
Pav, thank you for the wonderful introduction. My name is Abdelsalam Elaskary. I am from Alexandria, Egypt. I've been doing dental implantology for a long time. Doesn't matter how long. Anyway, to be able to answer your question, I would like to give you a little bit of update on the history of this. 6 years ago or 7 years ago, I was struggling to find assistance for those patients who has, disastrous sockets, as we call it. Those sockets that are really hopeless and you cannot do anything for it. And just people wants to keep it away. Just people wants to send it to someone, or they just tell them, we'll do some bridges, we keep you waiting for some time. So what I have experienced with my work is I have tried almost everything, almost all of those techniques, especially of those that you have mentioned, the early protocol, contour augmentation, the delayed, the whole thing. And as a result of my findings that was preliminary at that time, we found out that this is not what I really want to get to my patients. My patients would deserve something better. And so the search started like 7 or 8 years ago on something that would really help a lot. And would, the problems that we had is the waiting. So patients that wants to do or schedule to do some delayed protocol needs like a year of a treatment. And imagine a young lady that needs a year of treatment with possible provisional restorations that would survive a year. That's another question. Also, there was another problem, which is once you take tooth out, you have a total collapse of the whole tissues that needed to be regained and rebuilt with several complicated surgeries. And every time you do the surgery, then you have a recession or you have some remodeling, scar tissue formation, etc. So I started to come up with this development. It did not start like a holy inspiration. It was like step by step. We started to have some preliminary ideas, and then I started to have the full protocol, then updated later on. And exactly 5.5 years ago, I developed the whole protocol. And I came up with this idea that the question was, one, I needed to shorten the treatment time immensely. Two, immediacy and immediacy and immediacy. People now want to have immediate treatment. So that was number two. And number three, we needed to have predictability. Means that, yes, the people are right. All of those authors that have concluded that the placement of immediate implants in thin labial plate of bone is doomed to fail. Absolutely, I agree with that. Also, this labial plate will resorb. Absolutely, I agree with that. So we needed something that guarantees not just immediate result, but a very, very sustainable one. Something that stays for a long time. So we delivered this technique to cover all types of fresh extraction sites. So if you learn one technique, you will be able to treat all types of fresh extraction sockets in the aesthetic zone with single technique. So we treat with this technique thin labial plated bone cases. We treat deficient labial plated bone partially or fully, and we treat those sockets presented with active infection. So imagine you have a socket with a fistula tract or a sinus tract oozing pus. Then we have this protocol for you to immediately restore this with 100% of predictability. Nothing really is 100%, but very high level of predictability.
Sorry, so I was just going to clarify here that what you didn't do is you didn't look at all of these historic studies and say, well, actually, you know what? If you place an implant in thin labial bone, it can still be predictable. You actually accepted that hypothesis, and what you said is, actually, you know what? We need to come at this from a different angle. We need to change the way that we're looking at it. So what you're not saying is, you're not saying that these cases and these studies historically are inaccurate. What you're saying is there's a different way of executing treatment.
Absolutely.
Is that correct?
You're completely right. And it's a very well said phrases. So what I have decided is that, yes, we have all of those physiologic activities in the facial bone is legitimate. Also, for those who presented the delay approach, fully respectful, because this was the only effort available at that time. This is what was available in order to get rid of those infective signs and add some more keratinized tissues to the site. Yes, the delay approach was fine. Now we have a new concept, and is when we delivered this concept, I just did not want to showcase those cases or this outcome. I wanted to have something today, 12 or 13 randomized clinical control trial. So to be able to make a legitimate procedure, we wanted to have several studies to compare this procedure to the available ones. So we compared this procedure to the contour augmentation in a mega study, randomized control trial, a clinical trial that's 40 participants involved in this study. We also compared it to the IDR. We compared it to the ice cream cone technique. So we have almost 12 studies in order to deliver something that is legitimate, something that you could take with confidence because it's evidence-based, not just an innovation, that you should take back. So that was the main goal, to deliver something that is scientifically proven, something that is you can hold in your hand and you are confident that this is going to work well. Number two is that also we needed something, we need to provide you with longevity. Means what? Means that everywhere you go and you see all of those chauvinistic things on the podiums and on the media, especially the media, everyone's showing immediate result. Now, it's now. And this is not right. This is not, to me, it's not acceptable. What I would like to see is 6 months follow-up, 1 year follow-up, 2 years follow-up, 3 years follow-up. After that, today, we have 5 years follow-up for so many cases that we are publishing right now, a 5-year follow-up, just to show that this is not immediate one. This is something that will last for a long time. And the evolution of this technique just came as an umbrella that bypassed the physiologic labial plated bone resorption. We bypassed it with a concept called the bone shielding concept, when you can Google it. Number two, we came out with the 6-day protocol that is a protocol in the VST umbrella that helps to eradicate the infective signs in the socket to have a predictable regeneration. And we also have something that is called socket preservation VST, or VST socket preservation concept. It means that what if you don't really have any bone apical to the socket to place the implant? What would you do? So we come up with this concept just to help provide a predictable socket preservation as well. So we covered you all up with the several modules of VST concept. So that's how we provided the clinician with these type of tools in order to deal with any socket that he or she has in the office.
I mean, that sounds incredible. It sounds like what everybody wants, effectively, to find a predictable technique whereby we can reduce overall treatment times for patients. So this is something that I express a lot as well. Is, we often have these techniques where, yes, it's predictable, yes, it looks very nice, but it may take us a very long time to get there, and patients don't want that. Patients don't want multiple surgeries. Patients want a single surgery and they're done. So I undertake a lot of accelerated protocols, and I'm now at a point where I am in healed sites. I am placing and restoring the implant on the same visit. And it would be nice to learn more about this, so that even in compromised sockets where we need to do some level of grafting, that I can incorporate this and do this in one time as well. So, Dr. Elaskary, would you mind just going over very briefly what, are there particular materials that you use? Could you outline just briefly the technique for us? And so if you could go into a little bit more detail, that would be appreciated.
Yeah. When we developed this technique, we developed also the suitable biomaterials along with it to bypass the deleterious effect of labial plated bone resorption post-extraction. So, for example, I give you one example that makes this clear to the audience. Collagen membranes. Collagen membranes is a popular material that everyone is like to use, and is it probably routinely used in every office. However, collagen membranes do not give any clinical predictability. We see in the social media, we see a lot of those blanketing and tacking and suturing of those membranes, sausaging, and doing everything like this. But what about the long-term outcome of these concepts? What about the pitfalls, inherited pitfalls in the collagen membranes, which is space making, space maintenance? There is no space maintenance available at all in the collagen membranes. So if you have a lost wall of the labial plate, how would you put a collagen membrane and keep it sustaining the convexity of the socket? Doesn't work. Number two is the biodegradation rate or biodegradation speed of the collagen membranes. It will definitely biodegrade in maximum 2 months' time. That is prior to the regeneration rate of the bone. That's why in many instances, we do not find complete bone regeneration and some infiltration of the connective tissues or fibrous tissues inside the grafting material. That's because of the biodegradation rate of the collagen membranes. So we decided that forget about collagen membranes. That does not really, it's been 5.5 years, I never touched one collagen membrane. We exchanged this with a new type of regenerative components. One of them I will just highlight now, not really not in details, but we exchanged these collagen membranes with cortical membranes of origin. So we've used the flexible cortical membranes. That's now a game changer. That's now a completely game changer that would enhance your clinical outcome. Of course, when you come to the course, you will know what is the proper size. There are so many of them. What is the right material? What is the right components? What is the biodegradation rate? What is, etc., etc. We will reveal that. But I'm just trying to say that we have developed this in a consensus that helps you very much to deal with the pitfalls of regeneration. So what is good about just putting an immediate implant without rehabilitating the surrounding socket environment? Doesn't work. We need something that is predictable. That's how we came up with these biomaterials. On the other hand, just to keep things in the right location, we have realized that there is no available instruments to work inside the socket. There's nothing called socket instruments. Everything is not the socket. Everything is different. So I come up with a new set of instruments from Germany. I designed the whole concept. It's called Elaskary VST surgical instruments. It's a nice kit that is manufactured in Stoma in Germany, and it has a unique characters, unique instruments, and I will highlight one of them just as a teaser. For you, for whom are going to attend the workshop, will be able to use the whole thing. For example, now, you know, the debridement of the socket, is very important for the success of the graft. So I come up with something called Elaskary irrigation curette. So it's a curette that you irrigate with and clean the breed at the same time. So right. you clean flush. And how would you do that? Just, it has a hose, you know, the physio dispenser saline hose, just connect it to it and push the foot control. It will pump the saline through the curette. So this is one thing that is really interesting. And we have almost 10 genuine pieces of instruments this level. You have the new level of periotomes is called the hammerhead periotome. We have forklift retractor, etc. Something that is really different, and it's allows you, these instruments allows you to really deal with the socket in a very fast way and deal with the socket predictably, gently manage the all the socket related tissues, either hard or soft tissues. Also be able to deal and manage those new biomaterial stabilization along with. So this is also another component of the VST protocol, is to use this wonderful, genuinely made instruments in this technique.
That's fantastic. Yeah, I mean, it's always interesting that sometimes we see techniques and, we're like, oh, I'll give that a try. I'll use the instruments that I've currently got. And then you really struggle with it. And you wonder, why am I struggling with it? It's like, well, you need the right instrumentation for the techniques.
Exactly.
So, Dr. Elaskary, we've spoken about regenerating the bone, and getting, even when you've got absent labial plate or thin labial plate, that there are ways and materials now that we can predictably regenerate that. What about the soft tissue? Because in my experience, most implant cases, particularly in the aesthetic zone, they require soft tissue augmentation on some level or another. What are your thoughts on that?
For what reason? Why do you need soft tissue augmentation?
To prevent collapse and have adequate thickness to prevent periimplantitis in the future.
Okay. We have two indications here, two clinical scenarios. Either you have a very thin soft tissue with some soft tissue dehiscence, or you have intact soft tissue with acceptable thickness. If you have intact soft tissue with acceptable thickness that is even having some sort of recession, with the new biomaterials, the cortical membranes, we have an evidence from animal study that we have conducted that we could treat the recession using those materials. You don't need to use a connective tissue graft for that. Yes, we'll show these evidences in the workshop. On the other hand, if you are having a case or a clinical scenario with really thin soft tissue, you definitely need to augment the soft tissue with a connective tissue graft or alloderm or whatever substitutes that you have. But you need to have in mind the main reason of using soft tissue grafts is not to prevent bone resorption or not to minimize post-extraction bone resorption. It's not going to happen. It's evidenced in the literature. We are using connective tissue grafts just to stop further or to prevent the prevalence of midfacial recession. So it just helps thickening the soft tissue to stop or halt the recession, midfacial recession. That's it. So the main reason of using this is that. And we do not really have 5 or 6 years follow-up on connective tissue grafts a lot in the literature. So we use this on a short-sighted vision, but it's fine. We have a lot of publications around these type of grafts, but that's fine. I'm okay with that. So I only use these connective tissue grafts for one clinical scenario only, which is when you have intact, thin, soft tissue margin. Thin means that either the keratinized tissue band is less than 1 millimeter, or the keratinized tissue's thickness is less than 0.7 millimeters or 1 millimeter, something like that. So this is when I use the connective tissue graft, not between quote unquote, not on a staged approach. We use it in combination with the VST therapy.
Understood. That's very interesting. What I'd like to know more about as well, if that's okay, Prof, is you spoke about how you compared the VST technique to IDR technique. So a couple of the issues that I have with IDR technique, they're actually very simple issues. Firstly, sometimes the patient's like, you're not going elsewhere in my mouth. Okay, so you're automatically limited if they're just like, I don't want two surgical sites. And secondly, sometimes the third molar is still there. So in order to do the IDR technique properly, you've got to take the third molar out, wait for it to heal, then go back, which by its nature, it increases the length of time. So could you tell us what your findings were with regards to comparing VST to IDR technique? What did you find?
Well, you probably concluded it. Do I need to include more? Yes, maybe I would add a little bit
for the
more.
listeners. Yes, I've seen the study.
But you,
yes, but
you know what you have said is that it's completely true, which is one is that yes, most often people open up and cannot find this piece of bone to take from the tuberosity. And in other instances, in almost 80% of the cases, we could not, get into this third molar area unless we remove the third molar and we wait, or we remove it and take harvest at the same time, but not really predictable when the third molar is there. So you need some sort of accessibility in this location. That's one. Number two is that, let me ask you something. Of course, you learned a lot from the card mesh readings and writings and stuff like this. What type of bone that is involved in this location?
Well, it's generally very poor quality bone.
It's D5 bone.
Yeah, fatty.
So you have the D5 bone that is purely cancellous, and you take it and you put it on top of the implant facing the periosteum. What is supposed to happen to this bone?
Supposedly regenerate.
No. Supposedly 50% loss of the size of this bone as a result of bone remodeling. And this is not what I've said. This is in the literature. You lose 50% of the size of the grafted bone, especially if it is cancellous bone. That was our findings. Number three, the main basic concept of bone regeneration is the stability of the regenerative components.
Yes.
That's not available. You just dig it on top of the implant surface and not stabilizing the bone graft. So that's something that also contributes to the whole thing. We also have compared. That's an interest. This is another study now. I can just elaborate as well. It's the dual zone concept by Dennis Tarnow. Yes. Dennis Tarnow is my hero. But I have, we get this study that has, I think, 16 patients. We took 8 of them and we gave them the dual zone treatment. The 16 patients had thin labial plate bone. So we put, for the 8 patients, the dual zone grafting with the immediate implant placement, and we give the VST to the other 8 patients. Not the VST as in vestibular incision, but we have another, as I told you, we have another subcategory of the VST called the bone shielding for the intact thin walled sockets. So we did not give, we have a subsidiary of the VST. So we give them the bone shielding. So it's bone shielding versus dual zone. You can have this published in the, I think it's the, in one of the highest ranking journals anyway. So we found out that, when you put the bone under the thin labial plate bone, you put your bone graft, what the dual zone does is you put the bone in the bone zone area and in the soft tissue zone area, and you put it all the way up with screw retained restorations. So this is what they have concluded and what they come up with. What my findings is that when we put the bone underneath the labial plate bone, which is thin, everything is lost. Why? The remodeling and the resorption of the labial plate bone post-extraction results in osteoclastic activity around the external and the internal plates of this bone. This is actually also proven by Fickel from Germany. So when you have this induced osteoclastic activity, it also applies to the below bone graft. That's what helps accelerating the resorption of this bone graft. So this was our findings. We with the thin labial with the thin when you have a thin labial pit bone with thin soft tissue, recession is evident. When you have thick overlying soft tissue with thin labial pit bone, no recession that is possible, not really happening, but loss of the labial pit bone along with the regenerative components. So that is the power of research. That is the power of conducting randomized clinical control studies that really helps you where you are. We also have another protocol comparing the in thin labial pit bone. We compared the bone shielding concepts versus the partial extraction therapy. Like, for example, if you have a thin labial pit bone and a compromised tooth, hopeless to be taken out, what really is good to give to the patient? Do I give partial extraction therapy, or, which is proven and which is legitimate, of course, or the VST? I personally like very much the partial extraction therapy, socket shielding. But there are some difficulties, there are some requirements, because with the socket shielding, you need no periapical lesions, you need no root mobility, you need nothing. You need something that is completely nice. Everything has to be ideal to have this in action, to have it good. But our results was like similar. We were similar, and we were taking less time with the bone shielding concept versus the partial extraction therapy. But when you upgrade your socket to more than thin labial pit bone, then you have nothing but the VST.
Yeah. So do you employ the VST technique when you've got a thick labial plate of bone as well? Or in those cases, I'm happy with the biological processes here?
Absolutely. You answered it. I'm not applying this at all with the VST. If you have a thick labial pit bone, the only thing you need to do here is to follow the protocol. So I have listed the protocol in the workshop for dealing with thick labial pit bone, and what to do, what exactly the steps. And if you apply the steps, you're not going to get lost. But you don't need any VST or any even bone graft. I don't even graft those thick labial pit bone. The gap, no filling the gap for me. I don't fill the gap at all when you have a thick labial pit. If you define thick labial pit bone, it means that it's 1 millimeter up, not less.
Yes.
And not only that, but where to measure this thickness, that's also another very important point.
Yeah. I think one of the things that's abundantly clear, and this is something I'm a big proponent of as well, Prof, is that it's not just understanding the technique. The technique is a tool. The biomaterials are a tool. What we need to understand are the biological processes that underpin the healing and regenerative processes. That's what's really important. I think that's what's not explained enough, is people put too much emphasis on do this technique, but not enough on why, what's going on underneath. So it's been absolutely fantastic and fascinating listening to you, because you keep coming back to, well, if you think about what's happening, this is what's happening underneath. It's like, this is where most people get tripped up. Most people go, oh, dual zone socket therapy. Why? Because it's available in the literature. It's like, hang on, but what's going on underneath? What other things can you do?
Very cleverly stated.
Yeah. So it's absolutely it's a superb technique. And
let me interrupt you here and add one more thing that I probably did not add. I think this is going to be interesting for your followers and listeners.
Yeah.
In order to have this technique that provides this wonderful, fantastic aesthetic outcome, stable aesthetic outcome, we found out that the most factor that is responsible for post-extraction recession and for this poor aesthetic outcome, believe it or not the resorption of the labial pit bone, not the regenerative material. Believe it or not, it is the way you remove the tooth.
Yeah, I can believe that.
So let us just put between quote unquote atraumatic tooth removal. So what is atraumatic tooth removal? Nothing. There is no definition for this. It is the way you try to dig inside the sockets with your tools in order to take out the tooth. But how atraumatic is atraumatic? Nobody can answer that.
No.
So even in the literature, when you have a study that say we have less recession, tell me how did you remove this tooth? No one is stating this. No one is coming near to this. So whether you lacerate or you maybe divide the papillae or maybe avulve the labial plate, whatever. So that's how in the VST we came up with something different that is called the vestibular ropeless root removal concept.
Okay.
That's something for your audience to go. This is your tip to go. So we removed the remaining roots from a different route in order to preserve the peri-implant soft tissue area at the crevice. That's a very, very important point that really counts to the aesthetic outcome. I will keep this no more elaboration until we do the workshop.
So, Prof, thank you very much for joining me today. If people wanted to find you on Instagram, social media, what's the best way to follow you and learn more about it?
It's Dr. Abdel Salam Elaskary. It's my Instagram page, and on the social media on Facebook, it's also Abdel Salam Elaskary. And also the same name on LinkedIn, it's available. My website is askariimplants.com. And I will be more than happy to answer questions, to help if I can.
Thank you so much. And I think the other thing it'd be worthwhile pointing out is we've mentioned a couple of times that you do actually have a workshop. And I understand that more recently you finished a series of workshops in Europe, which unfortunately I couldn't make it to. But we are working on getting you over to the UK in 2025.
Perfect.
So
in this workshop, you are able to do many things. We have a special model that's called the VST model that is manufactured in Barcelona. And you have the kit that is manufactured in Stoma in Germany. And you have the biomaterials from OsteoBiol as well. And the implants that we got sometimes from BioHorizons. So with those type of combination, you will be able to do a wonderful learning experience for those who will attend.
That's amazing. So if anybody listening would be potentially interested in joining us for the workshop, we don't have dates yet, but as I said, we're probably looking at 2025. Please reach out to me on Instagram. Just send me over a message, and we'll put together a list of people who may be interested, and then closer towards the time we can send out invites, etc. But Prof, thank you so much for joining us today. As I said, this is. Unfortunately, because this is a podcast, it's predominantly audio, but you need to visually see the results that Prof is getting and read the papers as well, because the results are absolutely incredible. And as I mentioned, what's really nice about it is, for those of you listening, you know that I like autogenous bone. I still like autogenous bone. But as I mentioned, however, there are certain instances where patients are like, you're not going elsewhere in my mouth. Or the place where I want to harvest from, it might have other things in the way, or the whole multitude of reasons that,
absolutely,
whilst autogenous may be preferred, that we need to have other opportunities as a backup as well. And I love this technique. The results that you're getting.
Thank you so much.
Yeah.
Thank you for hosting me. It's a pleasure to be here, and I would love to meet with you in person and with your followers as well.
Yes, yeah, thank you so much. So, folks, thank you very much for joining us today. Please follow Dr. Elaskary and reach out to me if you're interested. Although the course is going to be run in the UK, it's open to anybody worldwide, really. So, if you are interested, we'll let you know dates as soon as we've got them. Professor, thank you so much for joining us today.
Thank you very much, Pav. Have a lovely day.